Good morning and welcome everyone. My name is Robert Kingston and I'm from the Outreach and Sales Division for Covered California. It's my pleasure to welcome all of our agents to the webinar today and to welcome Peter V. Lee, who will be presenting our webinar. A couple of notes for today's presentation. We will be accepting questions throughout via the chat window on the control pane. So if you are needing to ask a question at any point, you're welcome to submit those questions. We'll also be posting the slides for this webinar online and be sending out a link to all of our agents, as well as posting the broadcast in the future for the recording of the webinar. So thank you again for everyone's attendance, especially on short notice. And again, I'm proud to welcome Peter V. Lee, our Executive Director.
Thank you, Robert, and thank you so much for joining us. There's three things that I'd like to do and we'd like to do in this webinar. Is first, give a very high-level review of what happened in this last open enrollment that you were all so critically engaged in. Second, going to share a story of how healthcare and healthcare coverage is like seatbelts. Stay tuned for that. But most importantly, we want to share with you two policy issues that are coming before our board for action at the upcoming March board meeting. They both have significance for the agent community, and we wanted to make sure you were well aware of them and had the opportunity to weigh in. As Robert noted, you can make comments in the chat mode at any time. We won't respond to them, though, until the end of all the presentations. So we're not going to pause throughout. So if you're raising your hand on issues, people can actually respond in chat mode if you're saying something's not working, et cetera. But no, we'll take respond to questions and get your comments at the end of all the presentations. So first, open enrollment 6 for 2019. I know and have met many of you. I know the folks on this call. The vast majority have been with us since day one, shoulder to shoulder on what has been, in many ways, a wild ride. No year was that more the case than for 2019. As you all know, with the removal of the federal individual penalty mandate, we were in a different environment for the first time. California still leaned in a big way with advertising, outreach, and marketing. California, as always, still leaned in with seeking to support the agents throughout California who are really the bedrock of our enrollment efforts, enrolling about half of all the people that enroll through Covered California. What we see? A little over a month ago, we released a issue brief that I'd encourage you to look at, and we will send a link to that brief when we send the email out on the slides from this presentation. A couple things we found that I'm sure you found. We had a significant drop in new enrollment. People newly eligible in the individual market enrolled at about 24% lower rate than in the prior year. Now, our renewals look strong. So if you net new enrollments and renewals, we're at about the same 1.5 million. But renewals don't tell the story until those people pay their bills, as you well know. I would strongly encourage all of you to be doing whatever you do to bird dog, nudge, encourage people to pay their bill and bills to keep their coverage live. So we did an analysis of the open enrollment period to see, well, what happened, what didn't happen, what do we think mattered? We're very clear that what mattered was the penalty going away. And we saw two populations with significant drops in enrollment. And it wasn't young people, it wasn't older people, it wasn't by income, it was by first, a drop-off in people that otherwise last year selected bronze. That isn't a surprise, because people that are apt to buy bronze, whether subsidized or unsubsidized, are apt to be the most price-sensitive people and are apt to be healthier. Two communities that we would expect to be most affected by the removal of the penalty. The other community was the unsubsidized, where we saw substantially higher drops of enrollment. These are big issues. We are looking at them very closely. I do commend you this issue brief to see how it syncs up with your experience. It's a big deal. The things I'd flag for you is this next year is going to be another interesting year. There are very intensive discussions going on, led by Governor Gavin Newsom with the legislature to potentially do two things of very significant relevance to the individual market. Number one, to potentially implement a state-based penalty for not having individual coverage, and to expand subsidies, in particular to expand subsidies to address the cliff, to provide some financial help based on what healthcare costs as a percentage of income for people that make between 400 and 600% of poverty. I know many of you, depending on where you live, have had people rightly challenge you and say, how can you call this healthcare affordable when me, as a 63-year-old living in San Francisco, have to spend 25% of my income to have decent coverage? That's not affordable. They're right. That is baked into the law of the Affordable Care Act. Governor Newsom has made a proposal to not have that cliff at 400% of poverty. So that's foreshadowing some of the issues that will be coming down the track. With that, though, I'm going to turn into the presentation and what the policies are before us. So first, my slides don't advance. Sorry, folks, minor technical difficulty. There we go. So I want to frame this by a presentation I just made yesterday at our all-staff meeting on why patient-centered benefit designs and individual mandate are just like seatbelts. And you're going, seatbelts, what do you mean? Well, a couple things. We believe, and the Affordable Care Act is anchored in the fact that going without health care is the dumb thing to do. Many of you may be old enough to remember crash test dummies. Now, I'd remind you that when we all go out for a drive, good news, the vast majority of the time, we do not have accidents. When you drive, you do not have accidents. When people do today, they are far more likely to avoid major injury because of federal standards for seatbelts and the requirement that we wear seatbelts. And I want to draw some of the parallels to that and healthcare. First parallel, standards for seatbelts, wearing them and having good seatbelts. Seatbelts cut the risk of serious injury by 50%, reduce the risk of death by 45%. Having health insurance means, number one, you're more apt to get preventive tests and services, so you're unlikely to get very sick. Number two, if you get sick and show up with an awful injury in a hospital, that hospital will provide you services. You know this, but you may walk out with a $500,000 bill. That's why we want to have and need to have standards for health insurance. Let me take you back a few years in the automobile world. Before federal standards, there were no laws requiring use of seatbelts or design standards. Dummies, like this one, and people did not survive accidents. Now, this car on the left looks awfully similar to the '63 Chevy Nova convertible that I got to drive around across the country in. And remember, early seatbelts were only waist belts. What did that mean? If you had an accident and was wearing a seatbelt, many people suffered mammoth internal injuries. Things have changed. Where are we now? There are now very clear federal standards for seatbelts. They mean you buy a car, you don't need to be an expert in seatbelt design. You don't need to ask, does this seatbelt work for someone who's 6'4", but I'm actually only 5'3"? You don't need to worry about it. Every car in America has seatbelts that meet national standards. Similarly, the Affordable Care Act established national standards for essential benefit designs based on the fact that consumers didn't know enough to say, do I care about a lifetime max? I don't think so, because they didn't think they were going to stick. Some of them did and found a $200,000 cap, $1 million cap was meaningful. Others said, I didn't read the small print. I didn't notice that I didn't have mental health benefits. Boy, those matter to me now. We in California take those essential benefits further with our patient-centered benefit designs that you all know and are familiar with. So let's bring that to today. Today, there are federal standards. Most of us still don't have bad accidents, just like most of us don't use much health care, even though we have insurance. Today, seatbelts, airbags prevent serious injury, and people walk away from accidents. And for those with insurance coverage, they get the care they need and don't walk away with literally, potentially, hundreds, if not millions of dollars of debt. Well, what's the mandate look like for for seatbelts? The map on the left is the 49 states that require adults to wear seatbelts. I won't comment on the name of it's New Hampshire. They are known as the live free or die state. That's the only state in the U.S. that does not require seatbelts. I don't think they came up with their state motto after they made this decision, but it does seem kind of apropos. But I'd note 50 years ago, if you'd asked Americans, does it make sense to require people to wear seatbelts, they'd say, get out of my business. But requiring people to wear seatbelts means the individual is safer, and we all avoid mammoth healthcare costs by people going to the hospital, having mammoth injuries. It benefits the individual who's pushed to do the right thing and all of society. Where are we today after the federal repeal of the individual mandate requirement? There are now 3 states in the District of Columbia that have a mandate or penalty: Massachusetts, New Jersey, and Vermont. I will tell all of you that I'm spending all of next week in Washington talking to elected leaders, members of the Trump administration. I'm going to be touring the halls of Congress with representatives from the Massachusetts marketplace as well as the Washington state marketplace. While California last year in open enrollment saw a 24% drop in new enrollment, Massachusetts saw a 30% increase in their new enrollment. Massachusetts is a state that has had a penalty in place before the Affordable Care Act. It is now baked into that state's culture, just like wearing seatbelt requirements are baked into the cultures of all of America. And they saw the difference in their open enrollment. So thank you for letting me share that with you. I think we often talk about how do you talk about complex health policy issues in ways people can understand. I think people can understand seatbelts. They can understand why sometimes you need standards because we can't kick the tires of what goes into a seatbelt design. Let me now turn to the 2 topics at hand that the board of Covered California will be taking up for action at the March board meeting. The first is the potential of setting agent payment standards. Now, I've met many of you at this last year's run up to open enrollment. We hosted, I think, 11 sessions around the state that thousands of agents participated in. Many of you said, hey, we aren't getting paid enough, or said, boy, the payments we're receiving are too unstable. You need, at Covered California, to help us out, to make sure that we have a viable business model. So we took this to our board. I'm going to walk through what we took to them and where we are and get your input. First, we took to the board and explained, we think pretty clearly, the vital role that agents play in what we are doing in California, that half of the consumers that enroll through Covered California rely on a certified insurance agent. We believe your role is absolutely vital. Because of that, we conducted a deep evaluation of agent compensation programs going back over time, and we ended up with 4 major takeaways. First, and these are long-term issues, we think it's critical to look at agent compensation in the context of total acquisition costs. Now, we at Covered California spend over $100 million on our marketing efforts, advertising, et cetera, over $100 million. Health plans spend a lot on their marketing. Agents do a boatload of work and are paid in 2018 over $140 million. All of these costs are part of making sure we get people in the door, acquisition costs. We need to look at that in that context. Second, we think we need to look at and understand the adequacy of payments. Now, as you know, it's very hard to get into what's the exact right dollar amount, but we know we want to make sure that payments are adequate. Third, we, recognizing the value of the independent agent channel, want to make sure you have predictability. Many of you noted if we have major changes in commission payments from year to year, you can't make long-term plans. We want you to make long-term plans. We want you to be as committed to us and the individual market as we are to you, which means thinking not just 2 months ahead, but years ahead. And finally, we want to ensure that incentives to agents align with consumer protections. One of the things that is critical to that is, and you know this well, under our policies, you are required to help consumers find the best product for them, irrespective of what you might get paid. If one plan pays 4x of another plan, but that plan that pays less is a better plan in terms of cost and value for that consumer, your job is not to say what pays me more, but what aligns with getting consumer the best product. We monitor how agents are doing enrollment to make sure there aren't inappropriate steerage based on commissions. But all of these factors, elements we're looking at. Let me step back now and give you an overview of what's happened to insurance commission trends since before the ACA and over the last 5 years. So pre-ACA, the individual market had about 1.5 million people in it. And the vast majority of people enrolled came through agents. Agents at that point made on average 7% of premium. Now, in 2018, as a percentage of premium, that's dropped to 2.4%. Now, I will note that I don't think that's necessarily a bad thing. Before the ACA, you all had to help people go through risk underwriting. You had products that were phenomenally different. Today, they're standard benefit designs. Today, everyone is guaranteed issue. It's a different game. It's also a game in which there's many more people. So, instead of 1.5 million, over 2 million people in the individual market. But without a doubt, jumping back to 2014, the amount of money plans paid in commissions dropped almost by half in 1 year. Now, that year was also the year in which health plans for the first time had medical loss ratio standards, where they could not legally spend less than 80% of their premium dollars collected on healthcare. If they did, they had to pay back the difference to consumers. That put significant compression on agent commissions, as did the factors of now having Covered California in the game doing enrollment promotion. What we've seen since then is the net amount paid out to agents, 158 million in 2014, 144 million in 2018, bouncing around a little bit. But more importantly, we saw and we surveyed every one of our 11 plans. There is very, very wide variation. Now, I know many of you are far more expert in this than I, but going back to 2013, when agent commissions averaged 7%, that meant the per member per month commission was $20. Okay. In 2019, the average per member per month commission is $11. Now, even though $11 compared to 20, it's dropped a little less than 50%. Well, the percentage commission has dropped from 7% to 1.7%. Why is the dollar drop not as much? Because premiums have gone up a boatload. So the per member per month commission payment at $11 is less than it was in 2013, but because of medical inflation, it doesn't track to that 1/3 from the commission payment in percentage from 13 to 19. But let me note a couple other things. The all plan weighted average is at $11 or 1.7%. But we have a high of a plan that's paying over 4% and a low of a plan paying 0.9%. Now, these figures, I'll note, do not include all bonuses that all plans pay, because some plans have bonus payments. This is a standard rack rate commissions, but there is wide variation and spread. We committed to the agent community to look closely at this and consider what we should do. And I want to tell you where we are and what we're taking before the board. And then, again, after I go through this in the next presentation, we'll throw it open for comments and questions. First, we've been evaluating the potential of taking one of three policies to the board. The first is to establish minimum agent commissions for our qualified health plans. And I'd note if we were to do that, we would look at the current weighted average as a potential benchmark. Second is to set rules or limits on decreases in agent commissions to address many of your issue, which is in understanding and giving you certainty over time. And the third is take no action. Now, we will be bringing a recommendation to the board in March. I will note that at our February board meeting, a number of board members expressed concern about establishing minimum commissions. One of their concerns was that they were worried that if we established a minimum, there might be, quote unquote, a race to the bottom, where all plans then pay the minimum, which might end up meaning lower total dollars paid out to agents. These are tough issues. We want to make sure we have a marketplace that works for agents, because a marketplace that works for agents works for consumers. And that's who we care about in the end, with all due respect to you and the agent community. We want a program that works for consumers, that has a viable agent channel, which we think is phenomenally important. Now, I'll note, we welcome comments on this issue. And in the email, you'll get this PowerPoint, which has this link. If you have comments to make, don't worry if you queue up a comment on this webinar and don't get through because we have 9,000 comments to try to address. Send those by email by next Friday, and we will be compiling those to take them to the board. Excuse me. So that's the first issue. And again, I will note that I am both personally and we organizationally are very torn about this. We believe in markets. We believe in competition. Setting rates for agent commissions is a regulatory role that worries us. At the same time, we think it's imperative the individual market has a viable and vibrant agent community. The second issue I want to share with you is the first policy would relate to contracts with our health plans, telling them what they must do. The second policy relates to policies specifically for every certified agent. To be a certified agent, you must comply with certain policies. We do reviews, we do audits. Very, very infrequently, there are bad apples that we remove from being able to be a certified agent. It's incredibly rare because by and large, we got a lot of really good apples out there throughout California doing really good work. But you need to comply with our policies. One policy we are looking at relates to setting policies with regard to non-ACA compliant plans. What are we talking about there? The core thing we're talking about in this policy relates to healthcare sharing ministry plans. Now, I'd remind you that unlike the rest of the nation, California's legislature has banned short-term medical plans. There are still some non-insurance plans. And I know this is not the forum to debate and argue the legislature's action. It is absolutely the case that during special enrollment, short-term plans were the products that may be the only thing available for people that missed out. But the legislature's decision to ban short-term plans was based on the policy of encouraging in every way possible people that are eligible to enroll to do that during open enrollment, and for those that need to enroll through special enrollment should qualify based on a change of life circumstance. Well, what are healthcare sharing ministry plans? They are exempt under federal law from complying with the Affordable Care Act. They require a faith-based membership that pools resources. There is no guarantee by any set oversight that these entities have solvency standards met. Money goes into a pool, but there's no ratios of how much money is in that pool, such as insurers must have. There's no absolute obligation to reimburse healthcare costs, and there is no governmental oversight. We did a review of some of the major sharing ministry plans and compared them to a Covered California silver plan. Now, first, obviously, and you know this well, if you are eligible because it's open enrollment or eligible because you qualify during a special enrollment, you cannot be denied coverage through Covered California or the individual market from any plan by your health status, nor can you preclude coverage for pre-existing conditions. That is absolutely the opposite for these sharing ministry plans. In every case, these three major plans can deny coverage for people who have pre-existing health status conditions, or can deny coverage for particular pre-existing conditions. Do they cover essential minimum benefits? No. Do they require enrollment fees? Yes. Do they pay agent commissions? Yes. Now, I'm almost feel bad about sharing this information because I'll tell you in a moment that 9 out of 10 of our agents don't sell these. I hope when you see that they are paying 15 to 20% commissions, you don't all call them up and say, I want them as part of my book of business. But we're a transparency-based organization, so we're sharing the data that we've understood. Monthly premiums vary, depending on if you do get a subsidy or don't get a subsidy. It is not a surprise that these products are cheaper than standard benefit plans because of these policies you've seen, but also because of the benefits consumers receive. What are those benefits? Well, lifetime maximums. Some of the plans have a per incident maximum of $250,000. Others have $1 million. Is there an out-of-pocket maximum? It depends. Annual deductible? It depends. Primary care visits. And this is one that I was just floored by, that of course you get coverage with a silver plan. You see the primary care doc as many times as you want. In some of these products, they aren't covered. They're in essence major medical products, but do consumers know that? Unclear. Emergency room, variable. Prescription drugs. In most cases, it's not insurance. It is a discount program that you can get today by walking in and knocking on the door of Walmart or Walgreens. And finally, maternity coverage, in some cases not covered, et cetera. They are very variable. So what's the status of these plans in California and nationally? The best data we have is from the Association of Sharing Ministry Plans, which notes that approximately 1 million consumers nationally are enrolled today. That would mean about 100,000 Californians would have these. A lot of money is in them. We know and we've seen extensive marketing and media campaigns in the last year in California marketing these. We also have surveyed our agents, and among you, 9 out of 10 do not sell them, 88%. And 1 out of 10, 12%, currently sell these products. I will tell you that we are very concerned about them. We are concerned that someone walks into a storefront that says Covered California's name on the cover and walks into one of your agents wearing a Covered California shirt and walks out with a sharing ministry plan thinking it's a good deal, not recognizing that their pre-existing condition will not be covered, not recognizing that there is a $250,000 cap on a particular incident, not recognizing they may have no coverage for primary care. We're greatly concerned about that. We are particularly concerned about this in the context of the potential of California having that healthcare seatbelt requirement in 2020. If California institutes a state penalty for having coverage, it is likely the state would mimic federal rules for exemptions, which would include exempting from a penalty people that enroll in a shared ministry plan. Now, people can do that, but we want to make sure they do it on a well-informed basis. So we are considering 3 actions we might take. One is to prohibit Covered California certified agents from selling shared ministry plans. Now, for 9 out of 10 agents, it wouldn't affect them. They aren't doing it now. But for 10%, it would require them to stop selling these products. Second would be to require covered California certified agents to provide clear information about the risks and benefits of sharing ministry plans before enrolling in consumers, including that the plan is not a covered California plan, the nature of commissions, and what to look out for, and to require that information be verified by a signed, the consumer signing acknowledgement they understand this. The third is to take no action. Now, I will tell you, as we've been in these discussions, and looked at this deeply, again, we don't like being a regulator. So the idea of prohibiting these from being sold is something we are loath to do. But I will tell you that is staff's strong leaning to take to the board a policy of full disclosure. We are worried that people signing up for these products are not doing it fully informed about the risks and benefits they may be undertaking. So all of these two issues, both health plan policies on agent commissions and covered California's policies for sharing ministries, would take effect in 2020, not in 2019, and would be acted on at the upcoming board meeting. So just as we asked for comments by March 8th on the policies for qualified health plans, we welcome comments from you by next Friday on your perspective on this issue. With that, I'm going to turn it to questions, and Robert's going to be queuing up questions for me, though if they're really hard questions, I might ask either Robert or Terry Convey, the Director of Outreach and Sales, who is with me here today, to answer the questions or hear your comments. And I want to know what I'd ask these folks to do. We've gotten a lot of questions and comments in. And note, what we're going to do, if you have comments of good idea or bad idea, we're going to save those and not repeat them. And we will tally them up and use those to inform our thinking, but we won't repeat them that, you know, Bob said good idea or bad idea. And what I'd like to do is spend the first 10 minutes first just on the issue of setting minimum agent commissions or standards for the health plan. So let's spend, if you don't mind, try to weed through and we'll come to the sharing ministry comments and questions second. So let's do first 10 or 15 minutes on the issues with regard to setting standards or not for QHP commission payments.
Hello, everyone. This is Jamie Yang, the Senior Sales Manager. The first question, Peter, is Blue Shield and Kaiser's commission are really low, and they don't cover the cost of agents doing business. This makes it impossible to market. How much do you think this will impact the future enrollment numbers?
So when we did a deep review of agent commissions, it's not surprising, folks know this, that two of the plans that are below the weighted average of 1.7% are Kaiser and Blue Shield, two of the largest plans by total enrollment. Now, Kaiser has not changed their commissions since day one of the Affordable Care Act. They've not lowered their commissions. But is it enough? One of our challenges is getting in the place of judging what is enough. This is a market. Many agents it's working well for, but that's where we're nervous about setting a right amount. But we want you to have, and I put in air quotes, enough. We don't know what enough is. We've wrestled with this looking at our navigator payments, even at for those individuals that are complex, that can take hours to enroll and support, because we know well that many of you don't stop at the point of enrollment. You help them throughout the year. The per hour basis would be much more than agent commissions. At the same time, we also know that the vast majority of people renew without engaging with their agents. We also need to study more issues of what's the ratio of problems and issues that agents receive from different health plans. We have some data to show that people in Kaiser are more apt to, once they've been enrolled, need support from their agents. These are all some of the trade-off issues we're trying to understand and look at that we'd welcome your comments on as we decide what policy to make. Jamie?
Great. The next question is, why can't we have minimum agent commission requirement and set rules or limits on agent commission decreases?
And that's exactly the question before us. I would note that nowhere to our knowledge in the United States is there a minimum commission set. I would note, and I think many of you know this, that we had one plan a number of years ago that proposed to have a lower commission structure during special enrollment period. We did establish policies to say that was not allowed for qualified health plans. We didn't want health plans altering commission structures based on open enrollment and special enrollment. We do not want health plans altering commission structures that are at odds with our consumer first perspective, which includes having a balanced risk mix. But why not? I'm not going to go into all the arguments on pros and cons, but as you might imagine, there are, and I've heard from both agents, plans, and people who philosophically believe that you let markets figure out what people are paid. You don't set prices for what doctors are paid. You don't set prices for what agents are paid. You don't set prices for what one coffee shop pays another coffee shop employee. But the reason we are looking at this issue so carefully is we're worried. So we want to hear from you on which of those is more important, where you think we should draw the line, and if we should. Thank you. Next.
Yes, next question. Why can't Covered California pay an administrative fee per application on top of commissions that carriers pay, since carrier commission is so low?
Interesting question, and it's something we might look at over the long term. But you'll note the very first slide I referenced relative to this issue is we want to understand how agent commissions fit in to the total acquisition cost. Throughout the Affordable Care Act now, only 20% of the premiums can go to non-healthcare services. What does it take to get people insured in terms of outreach, getting them in the door, getting them through the process, keeping them retained, is something we in California have a better sense of than anyone in the nation, and it's complex. If we were adding a kicker, so to speak, on top of what agents paid, we would have to be adding premium to cover that. So our issue is throughout, we're looking at premiums. We're looking at keeping healthcare affordable, and part of that is keeping healthcare affordable by keeping a lot of people insured in a good risk mix. But those are the sorts of trade-offs that we need to look at. But it's an interesting suggestion. It's not one we would act on in the near term, but it might be something we look at over years to see how do we balance Covered California's direct spend compared to that made by health plans. So that's, again, these are all real. And I want to note one other thing, because I know we will not get to every comment or question. Every comment, though, that you've logged on in our chat system, we will be reviewing in detail and considering in our deliberations. And it's a really important thought, comment. We will be looking more at that as we go forward. Let's take two more questions or comments specific to the issue of agent commissions, and then we're going to move over to sharing ministries. Very
good. We have a question in which we are asking if you create a minimum commission floor, will Covered California risk the fact that Kaiser might pull out of the exchange?
You know, it's a really important question. And I'll note that we've had preliminary discussions with every one of our 11 health plans. And you will not be surprised that many plans, in particular those that pay less, are very concerned about the concept of having us tell them what they pay agents. Is that enough to have a plan pull out of the individual market? I can't speak for the plans, but that's why not only are we speaking to you, our truly vital partners in the agent community, but we're talking with the health plans this week and next as vital partners and making sure consumers have a range of good products available to them.
Can Covered California, in connection with mixed Medi-Cal families, can Covered California consider these types of policies and to how agents can get paid?
Well, again, this goes back to our ability to pay for people in the individual market. We do pay for mixed families for the parents. we do not pay for the kids who do not have premiums going through our plans. They have Medi-Cal payment. So that's an example, again, of what by law we can do and what's in many ways outside of our bailiwick, but it's a really important observation. I just want to be, it may not sound like enough, but we know this. We know that when you enroll a family that's a mixed family, you get a commission, and maybe it's a bigger commission from one plan or a lower commission from another plan only on the parents. Often, you spend a boatload of work helping that family's coverage challenge related to the kids on Medi-Cal. We know that issue. We are doing a lot of work at our end to try to smooth over some of the issues with counties to make that smoother. We do not, by a long shot, in any way minimize the importance of those efforts, and recognize that in many ways that effort for those kids is not compensated well or fairly. But it's really beyond the scope of our setting commissions, because Medi-Cal is not our business.
And moving on to shared ministry plans, we have a question which asks, will Covered California consider the cost in preventing ministry plans from being marketed, the cost of health coverage?
Well, it's a really important question. Is we won't, but our plans will. And I want to note something, that if we have an individual market of about a little over 2 million people. Our best guess is 100,000 people have opted in California to be in shared ministry plans. I can tell you with absolute certainty, those people who have enrolled in those plans are healthier on average than people that enroll in the individual market, because people that are sicker are screened out from coverage, et cetera. Which means if those 100,000 people were instead in the individual market, premiums would be lower for everybody. How much, I can't say. So, and this is an issue that we've had concerns about sharing ministry plans, impact on healthcare costs brought to us both by the agent, members of the agent community, and by health plans, saying we may not have short-term plans, but if there is a flood of people into sharing ministry plans, that will mean we will have higher costs for all Californians in future years.
Okay, next question. Can Covered California or California simply not allow ministry plans in California, like the prohibition against short-term plans?
Yeah, this is something that, well, first, Covered California cannot take any action of that sort. Our ambit of both responsibility and authority is to create and foster an individual market. These are not products. And my understanding, and I'm going to put this in mammoth caveat, and luckily my general counsel is not sitting next to me. I do believe these are established under federal law. They are absolutely not regulated by the California Department of Insurance or Department of Managed Healthcare, because they're not insurance. Might they be able to be regulated in some other ways? Maybe, but I hate to say it, I don't mean this in a pithy way, not our job that we can control. So we're looking at what is in our ambit. But a great question, and we'll take that back to our policy folks. And we've got time for a few more questions. And again, I do want to remind you, many people have weighed in with questions and comments. We won't be able to get to them all, but note, every comment you make, every question you make, we will be reviewing with care, as we will review with care any comments you make by next Friday. I would note, in addition, I want to be really clear about something. The reason we asked for comments by March 8th, the board meeting is on March 14th. And I want to note, one of the call outs is to CAHU, the California Association of Health Underwriters. We have a meeting scheduled with them in the coming days. CAHU has been a very good representative of the agent community. We appreciate they often testify at board meetings, provide comments. We will be engaging with them. But I'd also note that any agents are welcome to come to the board meeting in person or by phone to tell our board their perspective. That's a welcome invitation. The reason we asked for comments by March 8th is staff need to sort through those comments, need to do some of the balancing to then make a final recommendation to the board, which the board would act upon on March 14th. People could come to that March 14th board meeting, would then see and be reacting to a final recommendation, which we have not yet formulated. Terry.
Yes, next question. We do sell Christian care plans, and we do require full disclosure, but we believe some coverage is better than nothing. Could you comment on that?
You know, I think that this is exactly why this is a tough issue. And I don't know who that is, and I'm not going to ask you to out yourself. But for those of you that sell sharing ministry plans that have examples of full disclosure, please share those with us. Because it is absolutely the case, and we know this, that especially in a period when there are no more short-term plans, we know that there was a big drop in new enrollment in 2019. Many people did not use the open enrollment period they had available to them. For those individuals that knock on your door in August that have not had a change of life circumstance, they would not be eligible to enroll in a Covered California plan. For those individuals, a sharing ministry may be the only product they could enroll in. That's part of the balancing act. Now, in the absence of a penalty, that's a big issue. We believe the better choice, though, is to make sure everyone gets in the door during open enrollment. And one of the ways to nudge and push that is by having, at the high end, a prohibition or disclosure. So I think that comment is a very articulate comment of what we need to balance.
We have a final question, which really is of us. Would we be interested in some of the experiences where people have not gotten their claims paid by the sharing ministry plans?
This question really goes to the heart of some of our concerns, which is there is today no regulatory redress people have if a claim is not paid, if they feel that things aren't working, because these are unregulated entities. Now, we've heard some stories of consumers with problems, but remember, and I want to come back to, if I may, my story about seatbelts. The vast majority of people that buy sharing ministry plans don't use them because most of us don't get sick. Just like when most of us drive, we don't have accidents. So the vast majority of people that sign up for a sharing ministry plan, the fact that they don't cover a lot isn't a big deal because most of us don't need a lot. But it is giving for some people every year a sense of some real security, because it may be that something is better than nothing, but for others, false security, because it is coverage and not covering whole types of care and not having maximum protections that are there in the Affordable Care Act. Okay, with that, do we have any last questions, or am I wrapping it up? Wrapping it up. So I want to thank literally the hundreds of you that joined this call on fast notice. We know you're busy, but we really cannot say enough how much we appreciate what you do with us. California has been on the cutting edge of showing the nation how to expand coverage. These policies, both of these policies are examples of policies that have not been undertaken anywhere in the nation. They represent California continuing to wrestle with on the front edge of tough questions. But there's issues we welcome to wrestle with because your roles are so critical to us and to California's consumers. And we think it is so critical that California's consumers know what they're getting when they get it. That's something that we've been invested in from day one. I want to, again, thank you very much for joining this call and remind you that we're going to be sending an email to all of our 12,000 certified agents with a link to this PowerPoint and a reminder of what the issues are and how to comment, ideally by next Friday, March 8th. So with that, I want to thank you for not just, again, attending this call, but for all the work you do with us to help Californians get and keep healthcare that matters for them and changes their lives. Thank you all very much.